Good morning. Today we will be discussing the how to tackle challenging situation during phacoemulsification. So let's start with the challenges related to capsulotomy. So this is the case of white mature cattle, 67-year-old lady. And you can see that it's intumescent white the capsule with trypan blue. Now I am decompressing the intralingual fluid and I am trying to exist with the help of 23 gauge. Now you can see this is a totally a clear-cut Argentinian flag sign. Now I am in dilemma now how to tackle such situation. So, Dr. Sean,
Yes, sir.
how we could have prevented this situation?
Yeah, actually, this is clear. Pre-operatively only we can do a good examination. We can know that there are chances of such type of incidents. So, what we should do, we should be ready with the pre-operative things more. Like we should explain patient also. And another thing is that if I will do such cases, I will do it in block. So I will prefer block. And before block also, Dimox or acetamide or 1 day prior or same day, we can give to the patient. And that will definitely help. This is pre-operative. And post-operative, during operation, there are 2-3 things. First thing, this is the best that you have done with Trifine Blue staining. Another thing is that, sir, when we are going to happen this case, before that, think about that the CCC should be small. Just give a nick and then aspirate that cortical matter and then the pressure will be reduced. We are using good viscose, good type of cohesive, whatever it may be, but still we can get such type of incidents. So this is my opinion. And rest, with a small nick, you can aspirate the material and then the pressure will reduce and you can continue with the CCC.
Dr. Atul, how you like to proceed further? Do you want to
I like
continue
to
with
add,
Phaco, or you want to plan SICS or something?
just in Shones, I like to add one point. That is my observation. In such cases, always keep the Trypan Blue by clock for 2 minutes there under air. See, the Trypan Blue does so many times, these chances get reduced because the elasticity of the capsules get reduced with the Trypan Blue staying there for 2 minutes by clock. So, and I don't find, I have done in so many cases, and touchwood, since I am started doing this practice, I didn't get a single Argentinian flag. And the people said that the complications of blue on the endothelium, but I also didn't find anything there. So this is a very simple step, but it will save your life. Now, if at all these things happens, use of microcapsular excis forceps and scissors is very important. You can convert this into a keyhole sort of capsulotomy, give a nick at one end with a microcapsular excis scissor. Before that, try to aspirate whatever the liquefied cortex is there from that Argentinian flag. After that, put in good quality viscoelastic, give a cut and convert the CCC on both sides. So you will have an CCC like, may not be a keyhole, but opening at both ends. And you can do phaco provided you know that there is a chance that these
Tear might get
tear might be extended to the posterior side. So take a precautions while doing hydrodissection. Then while doing phaco also, don't try to stretch the fragments too much, because then there can be the tear might have extended to the zonules, so you may have a chances of PC, but you can manage this case easily.
Let's see what I have done. So, considering the hardness of the cataract, I straight away converted this case into SICs.
Excellent surgeries.
So this is the another. This is another case of hypermature cataract. You can see it's intumescent cataract. I just decompress the back with the help of 26 gauge needle with bevel down. Fluid, but I think it was not sufficient enough to decompress the back effectively. So as I started doing the Nexus started running away into the periphery. Maybe some residual intralentular pressure has caused this Nexus to run into the periphery. So I tried to pull it toward the center, but it was not possible. So I tried to do it from the other side.
Sir, I would like to add here that whenever you are expecting that the cataract is intumescent and such a type of things are going to happen, the first thing I will do that I will make cruciate opening. Instead of one single nick, I will do 3-4 small radiating cut, so that reduces the chances of getting it radial. Then second thing, I will never use needle cystotome. Though we all are used with the needle cystotome, in such a cases, the forceps is very handy. And I will try to do it a small baby rhexis. I will complete it baby rhexis. After baby rhexis, I will decompress whole of the back with bimanual I and A. Then with the help of micro scissor, I will give just one small nick and then convert it into the big rhexis. Again in this type of situation, when the rhexis is running out, the density of the cataract will matter more for me. If it is a NS4 or harder than that, then I will definitely convert to SICS. But if it is a soft mature cataract, we can definitely go ahead with the phaco.
So I decided to go ahead with the phaco.
Yes.
Same phaco parameters like low phaco, and like now. one more case. How to I'll show you.
It's for the sake of the,
yeah.
I think residents have also come. So this video will be very helpful, sir.
Okay.
So how many of you are used to micro rexis forcep? Yeah. So
Yeah.
Initial incision opening is linear.
Yeah.
If you can make it circular,
Yeah.
then the possibility of Argentinian flap is much less. It won't happen. And second thing, my regular practice is to do double rexis, as has been pointed
yeah.
out.
You have to first
Yeah.
do a baby rexis and then you
And then,
enlarge it. Right?
then with the help of a Simcoe cannula, you clear and then do it. But if you can make it a C type of initial opening, it won't happen.
That's why I said ki make a cruciate incisions, not exactly see. Make 3-4 small cuts in the center, so that if one cut get extended, you will get a second cut to convert it into the rexis. So instead of doing one single nick, if you make a star shape incision in the center, so that helps a lot, because that star shape incision that will never go radial. That will stay in the center.
We'll go to another video.
Yes, yes. I agree with sir. Sir said there should be a small.
Yeah. With the 26 watts needle only, you make a cruciate incision in the center, star shape.
Sir is also right. Make one small CCC, aspirate the material, and then again with the capsule or scissor, you can extend the CCC. That is good idea.
Okay, Sean, we'll go to next case. That is the intraoperative hard eye.
Just 1 second, sir. Before we, for the CCC, I'd just like to sum up, take home message for the students especially, that yes, if you can see a hyper intumescent. Hello, am I audible? Yeah. So first step, what we, those who missed out. So first, in the first video, sir had shown that debulking is important. See that the pressures, it is hypotony is achieved well. Debulk it with the small nick, and then like we have just discussed all. So make those nicks circular nick or a T nick also helps in. Otherwise, in the first nick itself, you get a Argentinian flap sign. So if you have to avoid it, do it. And if at all, if you don't panic, if you get a Argentinian flap sign, there is, you can just make a cut through the micro scissors, and then you can go on doing that. So even that is possible, because while learning you get all this. It's not possible that in the first, this is specially for the PGs, so I would like to tell that even if you get, don't panic. You can go around converting it.
Of intraocular hard eye. Can you show? So this is the gauze needle, and you see that
Music is increasing that technicality.
you would get misdirected into see, this is also another hard cataract case. 82-year-old male with almost one-eyed patient. So after doing from the pars plana, aspirate little fluid. So I will show you how to do this pars plana aspiration with the help of there are many methods of tackling this situation. Some people use 23 bars trocar camera. But the needle, I think needle is much easier because it is available easier because of my trocar camera. fastly achieve the normal intraocular pressure. Right, Rakesh? Can you
So
elaborate?
only thing,
something?
because you need to be very accurate when you are using a needle. If you have a trocar and cannula, which is not very expensive, as a anterior segment, as a primary retina surgeon, because we still say because trocar canal length is guarded. So you are not going very deep. You are not accidentally touching the PC. What? Because if you are not very fine, you may just touch the needle with the over the PC. Trocar cannula just a small nick, and with the cannula, since that opening is quite big, so you get a good amount of fluid. So, but you need to practice both. You may or may not have a trocar cannula, but needle is always available. So what sir has said, because you have to be very available. Once you release the fluid, use good amount of viscoelastic, preferably some sodium halide, because which will give a good chamber stability. But then you need to practice with both. Needle, which is easily available. If you have trocar and cannula, which is like multifunctional. It can be used for this. It can be used for many other reasons. In case of vitrectomy, if you want to use an endoilluminator. So simple trocar cannula 3-side along with the endoilluminator must need to have with your anterior segment surgeon.
Those actually who are anterior segment surgeons who are not used for the using of trocar cannula and they are fear of an vitrectomy or something like this. Even if what is my observation is, even if you put a needle, calculate 3.5 millimeter from that, put a needle, don't aspirate, just put a needle. That also sometimes equilibrate the pressure, because there's a small, you should not need a large amount of fluid to be drained out, because pulling sometimes you can drag vitreous or maybe some sort of fear in the mind of anterior vitreous segment surgeon. So if that thing also works, our purpose is solved. The pressure is that little bit released, you can continue your surgery. So that is my observation, because I always fear while pulling, I might pull something or vitreous might get dragged. That's why I said.
Okay, can we go ahead with
One,
the
one
another
thing,
case?
just I want to add one thing, that you cannot prevent these complications. These complications are going to happen, whatever and whichever precautions you take. So no need to worry. Just day before yesterday, I was just cleaning the posterior capsule tags with the just hydrojet. Normally, just whatever we do after irrigation aspiration, we just 1 or 2 cc of the fluid BSS we push towards the posterior capsule and we clean the tags. And I have just cleaned the tags, and that time this happened, intraoperative hard eye. Somehow that fluid escaped through the zonules and suddenly the whole thing becomes very hard. So no need to worry about it, but the only thing is that you have to work immediately and very fast. If you wait for some times, then the things may become worsen.
So you have to keep in your mind that
Yes.
such situation can exist. Like you have to be careful regarding this. Okay, now 24 gauge. You can use 23. You can use 24. Yeah, as it is. If you think that it's leaking too much, you can suture it later on. Yeah. Okay, now let's see this video. No, 24, 23, or at the most 25. If you use a higher gauge needle, you will not be able to aspirate quickly. 1.5 inch.
Best is 24.
So this is the case of a hard cataract. I'm doing the phaco, and you can see there is a nice hydrodissection, and I'm rotating the nucleus nicely. Case was straightforward. Now I'm doing the phaco. I'm doing the divide and conquer technique, and you can see I'm trying to now chopping each particular fragment. But while using carefully, while doing the chopping, I lost the grip on that fragment, and suddenly the chamber shallowed suddenly. Once I clear this fragment, see what happened. What has caused this problem? What are the causes for this problem? Right? Why this has happened in this case?
You can explain.
Yeah, Atul?
So can I? May I?
Yeah.
Yes.
Go ahead. Please.
Yeah. So first of all, I think we should be well prepared for cases, pseudo exfoliation cases. Those pupils, a thorough pre-operatively, good examination, slit lamp examination is very important in each case. See how the nucleus is. If you feel that the anterior chamber is irregular, pre-operatively or on table also, if it is, so suspect if it is well formed, good dilated, mid dilated pupils also, you have this scare that okay, some complication may occur in drop. So first, good history, find out if there is any history of if the patient has any uveitis or pseudo exfoliation. If on slit lamp you find if it is something is there, and intraoperatively during that if you find that the anterior chamber is not shallow, that is a very not regular, that is a good sign to tell you that you have to be very careful doing this. And then again during the management, because of that one loss of that fragment, that itself gave a tag to it, and then that was the reason for the dialysis, I suppose.
The question of the zonular dialysis, this is a very serious complication of cataract surgery, right? And putting it can jeopardize your putting the proper oil in the bag, right? So the CTR is very helpful in this condition. Before just putting the lens, you can put the CTR. So the removal of the cortex is very difficult in such situation. So there is no counter pressure exerted by the collapsed bag. So try to remove as much as possible the cortex and then put the CTR, right? Once you put the CTR, remove of the cortex, you get trapped in between the CTR and the capsular bag. So I am trying to remove as much as the cortex before I put the CTR.
Try to have a circumferential, pull it circumferential rather than pulling it straight. The classical teaching that
Otherwise you will unseat the zonules and it will increase the zonular dialysis. Atul is saying right.
this is a classical teaching. No? You have to aspirate the cortex from the towards the center. You should not do in this case. Even in the routine case also, if you try to do it.
The CTR, everyone must learn how to what are the indication of CTR, what are the methods of inserting the CTR, and what are the limitations of CTR, right? CTR is a very wonderful device. If you land into a zonular there is some problem during Phaco, it can convert disastrous situation into a successful outcome by allowing safer Phaco and oil placement in the bag, right? Here I have done the freehand technique and dialing technique. Go and dialing inside the bag.
So as two tips in putting CTR. Whenever you put a CTR, the leading part should not be in the subluxated area. It should be away from that. And whenever you try to put the two eyelets in the of CTR in the bag, you see to it that they are away from the area the bag is subluxated. So these 2 points, if you start putting CTR in from the subluxated part, there is a chance that you might increase the zonular dialysis.
Extension.
Yes. During that CTR, how to put that is also a technique. Like through the, it should not be towards the main port. It should be through the side port. That is more. So many people used to put from the main port, and that aqueous will again or vitreous will come. Yes.
See, there are two techniques of insertion of technique. One is manually, you can inject there are
One take-home message is that I request all of those who have not used or who have not put CTR, please try to put CTR in normal phaco cases. Try to learn and try to see how easy it is to put. Once you get used to in a normal cases, then and then you will be able to put it in a crisis cases. Otherwise, in crisis cases, our heart rate is almost 110, 120, and in that we'll make mistakes. So I request you, all of you, put the CTR in normal 5-10 cases. Once you used to it, once you used to get the feel of CTR, then it's not a big issue in a crisis cases.
Size of dials.
No. But never. But because if it is a pseudo exfoliation case, in after 3 months, 4 months, 5 months, the whole bag lens complex may subluxate and it came anteriorly. So if you are suspecting it is a pseudo exfoliation, though the subluxation is at 2 clock hours or 3 clock hours, it is always better to put a CTR.
We had a feel that our lens haptic is supporting that subluxated area. Maybe we can put 3-piece IOL, more support, but with time there will be a fibrosis of the bag. And when there will be a fibrosis of the bag, these things are not going to put that much counter pressure to prevent that. So it's better always to put CTR, whatever with the hours of subluxation from 1 to 3.
See this now. What is happening now? I am trying to. This is a hard cataract. I am trying to chop the nucleus. There was a very ineffective trenching of this hard nucleus. Now I am trying to do the chop of that nucleus base. And see now what is happening. Look carefully. I lost the grip and see what has happened. Visual outcome of the patient. So we straight away converted and planned the SI. So now we'll go to another.
So again, if you had seen before removing the nucleus, he has just put a relaxing cut. Don't just directly put it. Try to remove the nucleus directly from the bag, because otherwise the whole bag will come. So just put a 2 relaxing cut, get the nucleus into AC, and then remove it to the small incision.
Now she's a 68-year-old lady, and she was having hard cataract with a semi-dilated pupil. The pupil was almost around 4.5 into 5. I was in dilemma whether to use BHS ring or hooks, or should I get away. I thought I will get away with this. So using with good viscoelastic and quick mixes, to manage such a hard nuclear plate with a small pupil?
So typical surgeon has gone into the VIP syndrome. The patient is a gynecologist. You are into that mental stress. Pupil cataract is hard. Pupil is small. So just keep yourself. First thing is calm. Don't just get into panic mode and do something wrong, which will create more complication. Simple thing is a nuclear plate. You have removed the upper part, but you have not removed the nuclear plate. Here comes the OVD, which acts as a third hand, helping hand. So you need to start, see that your chamber is formed, which will help to maintain the dilatation of the pupil. Put cohevis or sodium hyalurate, preferably 1.8, which goes sub-rexis. So it will help to release that plate coming out of at that, and then you can complete your phaco. So this is what I usually do, but any other thing?
I will show what I have done.
Yeah.
Yes, Atul, do you want to say anything? Like how should we manage this case now?
Initially, at least, if you first you should try to use intracameral things to dilate the pupil.
Yeah.
If it
Yeah,
is
I tried actually. I
yeah,
tried.
Then
But
if it
because of this touching, mechanical touching to
Yeah.
the iris with a lot of manipulation,
Then
it has resulted to miosis.
in such cases, if you are not able to break the nucleus and the pupil is getting small, the intracameral things are not working, even with the viscodilation is also not possible, then I think the best way is put in something to dilate, keep the pupil away from the field, either hooks or ring, something like that, so that it will make your job easy.
Okay, I'll show you what I have done here. So again, I lift up one of the fragment, but on the this when I was using the grip, I'm not making a So what I did is I manually, with the help of system, I manually get that inside the chamber.
So again, you create a bed of some OVD, preferably sodium hyalurate, because that will stay in that capsule, and then you can easily manually lift it up. So you need to have some extra support of cohevis, which is going to create that support, and then you can easily lift what sir is doing.
The rest of the thing was quite easy.
Here I think the main problem was the posterior plate was not cracked. If the posterior plate would have been cracked, then the pupil is not the issue. So whenever you are dealing with the small pupil, make always sure that central drain should be deep, proper deep, regular, and you have to get a one single central single break. If your posterior plate get break na, the things will happen smoothly.
I always prefer or suggest to have a direct chop in such cases, small pupil, hard cataract, because that that's some time after you start manipulating inside the eye, maybe doing one trench, another trench. After manipulation, the small pupil will automatically start coming down. So you lost that precious period. So in the first instance only, you know your mind is you're preparing with a small pupil, cataract is hard, small trench, go directly, and the first chop only if through and through, then even if the pupil becomes 4 millimeters, still you can manage.
Sir,
Please show the next video.
And don't feel ashamed of putting iris hooks, because once the rexis is done, it is very difficult to put the BX, because you are always in a dilemma whether you are putting BX inside the rexis or in between iris and this. So if after rexis there is only one option, you can put two hooks. Even if you put two hooks temporarily, means that 6 o'clock position oppositely, then also you can manage this case very well.
sir, instead of it's just my opinion, if before trying with the visco and trying to remove the plate, why can't we just go the trial of hydrodissation first, trying to remove the plate first with hydrodissation and then we can
You should with the hydrodissection definitely it will come, but again that while doing hydrodissection the pupil will get constrict, so that is a problem. So you have to use good visco, bring the nucleus like that only with the either good dialer or this thing, then only it will come. Hydrodissection won't work in such
So in
cases.
a soft cataract with a good pupillary dilatation, your hydro will work. But here the challenge is the nuclear plate and the small pupil. So if you want to handle both the cases, then probably visco was better.
And those coming from, I am coming from a government setup when things are not available, neither BX rings or so I don't shy away from doing sphincterotomies also. So just two nicks small, so it is not going to affect the pupil much, but it helps in dilating the pupil.
So now we'll go with the challenges related to the intraocular lens implantation. Please put the music on. Sound, please. So this is the case of combined surgery, like cataract with trabeculectomy with foldable IOL. Everything was nice. So it's almost a routine case. And I'm trying to put preloaded foldable hydrophobic lens. Now see what has happened, right? You must know the technique of preloaded IOL implantation beforehand. Now you can see I have broken the haptic
to be a new innovation.
So though we are doctors, we need lots of engineering skills to implant the IOL. And the thing is that we are in a pseudo happy phase that we have completed surgery, phaco surgery successfully. So now what's happened? What's the big deal? Just we have to implant the IOL, and most of the things happen in that pseudo happy phase. So for this we need lot of engineering skills also. So we are not only doctor, we are engineers also.
Thanks, Dr. Suhas sir, for showing us these videos, because we all have experienced this, but we don't have the guts to show it. So, frankly.
Anything to say, Atul?
Very nice, very nicely you have shown your innovations will really going to work, because
Thank you.
only thing I think we need which cartridge you use for
I
that?
use the 3.2, but
It's a A cartridge, huh?
right. But certain oil materials are quite rigid, like Johnson and Johnson and that.
Yeah.
So we are planning to increase the incision size of almost around 3.4. If
What-
you give
what-
the vertical nick to the 3.2 cartridge, it will come out, but it takes lot of efforts to take it out.
My way of doing such cases, no financial interest, but I had a set of epsilon peoples providing IOL holding forceps and cutting scissor. In the first case, what when you are doing the cutting the IOL, you are not holding the lens, so the lens was just moving and twisting like that. So that's why there is a chance of desmates or capsular tear or zonal diasis, iridolysis. So many things can happen. But if you put a good viscoelastic below and a good viscoelastic above the IOL, cut IOL, you go from the side port, the epsilon forceps has the same sort of serrated forceps. You hold it. And you hold it, once your hold is there, you put a scissor through your 2.8 incision, it will go. You don't have to cut through and through also. You cut up to the 75%, then pull one haptic, automatically the another haptic will roll on like this. So that is my observation.
And another thing is that if you think that we can't do all this thing, just extend the incision and remove the lens. So this is our safest thing. Don't try to, because so many times we just get panic and we try to damage posterior capsule also and cornea also. So that will be more hazardous for patient also and for us also. So just extend this thing and bring because so many times happens with me. So I just extend. Don't hesitate, because even though you are a very skillful surgeon, anything can happen.
But you lose the advantages of small incision surgeries, phaco, post-op astigmatism, patient's comfort level. You are putting sutures there. So if it is possible to do it through 2.8 or maximum 3 millimeter incision, then why can't we do it?
And for the PG students, ma'am, it is better. You should learn CCC better, SICS also better, because don't go directly for the phaco. So that is also a take-home message for the PG students.
One last thing, though it is not technically correct, but if you have a smaller CCC and you are putting a monofocal lens, even if one haptic is break and you think that the IOL is sitting properly inside the bag, provided your CCC is very short, like a 4 millimeter, you can leave it as it is. If it is a monofocal lens, it is not going to decenter a lot. It will remain in the center. Though I am not technically correct saying.
Amit,
Just-
now we'll go.
Just last one addition, most of these preloaded lenses, now currently we have very few limited company which has a preloaded lenses. Most of these preloaded lenses, they use certain chemical for inside that cartridge. So always, rather than putting a direct visco, just first clear with a hydro, just put a fluid, just wash out that chemical and then put a visco. Use very minimal amount of visco, because then right now we don't see the IOL getting broken or anything, but we see sometimes haptic getting stuck to the optic, and that remains so badly stuck it does not get open up when you actually inject it. So first do a good irrigation with a normal fluid, then put a little bit visco and then you can inject. So that's a good and other thing because you need to learn IOL cuttings and with a forceps. That's a must for now everyone.
First of all, for the PGs, you have to first know how to load an IOL. Do not leave it to your assistant. That is the first thing. Next, you assess that the IOL has to be freely mobile within the cartridge. That is why first you inject some amount of viscoelastic in the flanges and also in the main port. That is the main tunnel. And then you put the lens inside it, and then you move the lens a little bit so that you become assured that the lens is moving. Next, for the Indian hydrophobic lenses, because in teaching hospitals most probably you will be putting that, try to put the behind haptic under the optic. That will save a lot of your effort while you put the lens, and that will give you a lot of cases where you will not lose your. For Indian hydrophobic lenses, you have to put the posterior haptic under the optic. Under the optic. Because I have torn 20 lenses of Oro. That Oro people came and they told me, sir, you are putting these lenses. This is our lens, you put with this cartridge. I said, you come to my OT and I will show you how I tear it. I am tearing it every day. And as sir has said that you always have to hold the lens before cutting the lens. Because I did cut all those 20 lenses. And then I learned this trick, and once I started doing this, just put the trailing haptic under the optic and just make sure that the lens is moving before you shut it. Then no other lenses is going to give you that nightmare.
Okay,
Wonderful
now we'll
trick.
go on to one more video.
No, it's not getting twisted. I do it regularly.
Okay, now we'll go on to another case, another interesting case. Here, can anybody tell what type of cataract is this? Is this a posterior subcapsular cataract? CSC cataract, right? Or is it a hidden camouflage posterior polar cataract? Okay, now we'll see what has happened with this. So, thinking that it's a posterior subcapsular cataract, I went ahead for Phaco. I did not assume that it is a hidden posterior cataract. And taking this case as a routine case of posterior subcapsular cataract, after staining the capsule and after doing the capsular rhexis,
So the posterior polar cataracts are the most mysterious cataracts of all type. You name any complication and that can happen in posterior polar cataract.
How will you like to proceed in this case? Do you want to put lens inside the capsular bag or over the intercapsular support?
So that was the right decision. If you can really manage, you can do a PCC, but PCC has to be really small. If your PCC is big, then I would prefer to put a 3-piece IOL in the sulcus, not in the bag. But if your PCC is smaller than your capsule, entire capsule, you might take a risk of putting a 3-piece IOL with an optic capture, or you can put it in the bag. That is something which you are really trained for that. But your PCC has to be smaller than your anterior capsular axis. Otherwise, for a safely, you have to just put a 3-piece IOL in the sulcus and you'll be to go ahead and finish this case. Another thing, I don't really would do this hydrojet cleaning. I would do a very simple vacuum cleaning, or maybe with a cannula, just a simple pampering, I would say. I would not do any polish or anything. I would just say a simple cleaning superficial rather than putting a certain jet of the fluid, because that can always sometime behave miserably. So that probably
I also, modified this technique. Now
Yeah.
I was using 5 cc syringe. Though the force of hydrojet was quite high, so
Yeah.
I started using 2 cc syringe with less fluid.
because normally I use a manual
Gentle push.
AC Mentum with the aspiration cannula. With the aspiration cannula, I just gently slide it over that PC area rather than doing any vacuum polishing or anything. And I'm most of the time I am get through for without any PCC or any PCR.
Sir, one more thing what I observe, when everything is over, you just remove both the, not both, the irrigation counter you removed immediately, and suddenly the pressure started. So that is the thing that whenever you are suspecting such type of cases, the irrigation port should be inside, put viscoat from another side. The chamber stability has to be there. Otherwise, if the chamber stability will lose, definitely this will pop up and PC tear will be there. This is my personal experience for
Yes, Atul.
Whenever you see a case, you are in dilemma whether it is a PSC or a posterior polar. Do it as a posterior polar. The planning starts from the beginning. When you do a CCC, you keep in mind that you might have to put a 3-piece IOL. So don't do a circular CCC. I always do a vertical CCC, oval CCC, so that even if the something goes wrong, I have two sides which are very strong for my 3-piece IOL to hold. Then second thing, don't do hydrodissection. You do hydrodelineation, that too inside out as suggested by Dr. Vasoda sir. Give a trench and from the inside the trench, as the sir shows, do like that. Never ever in such cases take out the phaco probe, irrigation aspiration port directly. Whenever you want to take out first, that's why you have to do the practice in a routine cases. Otherwise your hand starts moving like this only, because you are not accustomed to the left hand. So the left hand, with the left hand visco inside, and then slowly you take the out. Finally, when you do all this removal, always try to remove the nucleus like in pieces. Just, it's not like you have to remove the whole in one time. You have to take one piece from this quadrant, one piece from that, one piece. Slowly everything get accustomed in the center, and at the last you take that last piece. Finally, I personally never ever touch that PC area. No hydrojet, no waste, nothing, because that is the weakest point. They just need a reason to break. You put a water thing, even you put a cannula there to rub it, it gets break. So the whole thing is okay now, don't play. Just even don't inject the IOL under hydro in such cases. You put in visco, put in lens. Now you can do afterwards, NDAG is there for to remove whatever there is inside, even if it is the posterior plate. So these are my methodology when I plan these cases. This is where I deal it.
Don't hydrate the wounds vigorously. I have got trained while hydrating the wounds of the side port. You are just hydrating the side port, and I was just checking whether the chamber is taut or not. I was just tapping with the cannula, suddenly PC rupture. One thing that regarding inside out hydro, there are specially designed cannulas where the tip is on the upper side. Tip is not on the center, like what we are using that hydrodissection cannula. Here the tip of the jet is on the upper side. So whenever you are pushing that jet, instead of that jet coming from the tip of the nozzle, it will come from the upper side of the nozzle. So it will give you proper inside out delamination.
Now see here.
Basically, you have also used the manual separation to separate the epinucleus from the nucleus.
Correct.
So how effective is that from the normal hydrodelineation? Like,
Now I'm used to it. Any posterior capsule, I try to separate it mechanically. It doesn't harm much.
Doesn't harm much.
I don't know the effectivity, how much, but definitely the inside-out hydrodelineation works wonderfully. It has a lot of effects.
So what I do routinely is do a trench and then do a inside-out delineation rather than doing a direct hydrodelineation. That is much more safer than doing any other maneuver. In his hand, probably that is working very well both the time, but it's your experience over a period of time. But inside-out hydrodelineation probably maybe a simple trench that will reduce the pressure also, and that you get enough space to pass your fluid also.
Most of the time, these PPC cataracts you saw, it's a hardly soft cataracts. The main problem happens when you don't know that something lies behind. You have a mature cataract. You never thought it is a posterior polar cataract. For that, the OCT rolls come. There is a very good paper from Dr. GP218 sir. He had given all the stages. The OCT should be with an IOL Master 700 that, and even in those patients where you can't see it, you can have an idea whether are you going to deal with an PPC or not.
Yeah. Which? Cortex. Bimanual. Yeah.
So with the help of dialer, you just put the dialer from the side port. With the help of dialer, you just hook that piece, just bring slightly forward, put a visco, and with the help of probe, you can remove it easily. But you have to take the help of dialer from the side port, opposite to that main incision. You just go there, hook it, and bring it in the center.
And always use bimanual.
No, but you have to do it, sir. You have to do it. Yes, sir. Yes, sir. Yes, sir.
There is one more way that you can do. You can, the Phaco probe is like this. So you can simply rotate it and it comes like this.
But there are chances that Phaco probe might catch the posterior capsule. So it is always better to put the visco from the side port.
No, he is talking about nucleotomy.
Sub-incisional fragment. So sub-incisional fragment you cannot catch with the Phaco probe.
No, if it is like this, so you can hold here and then you bring it like this.
Yeah, for that only I am telling you that with the help of dialer you just pull it toward the center and then grab it.
I hope this course will be useful to you.
Okay.
Thank you.
Thank you. Cortex. With the help of bimanual only.
Bimanual is the
one
best
technique,
for such use.
One technique that is the COPS technique.
हाँ,
You have to
Phaco.
position your aspiration cannula just behind the entire capsule. Position it, then you have to occlude with the cortex. Swap it and pull it towards the posterior. There is one beautiful video of Dr. Basavada sir. They call it as the COPS technique. Position it, occlude it, swap it and pull it posterior. So in that time you are always sure that you are removing the cortex.
बंद झालं ना ह्या ना आता इकडे